Good morning, everyone, and welcome to the third and final day of the Oley2022 Virtual Conference Intestinal Failure Workshop. I'm Beth Gore, the new Oley Foundation Executive Director, and I'll be facilitating the session today. So if you've not heard or not been here the last couple of days, the longtime Executive Director and face of Oley, Joan Bishop, has become the Executive Director Emeritus. Now, she's going to still be around. She's going to be sharing her talents and doing the fun stuff and less of the day-to-day operations. And although she will be very involved in helping with what we are planning to be our in-person virtual conference next year with a in-person conference with a virtual arm. As we said over the past couple of days, we would have all loved to have been meeting in person this year, but we are grateful to be with you virtually. And we recognize that this allows many of our members to attend who would not have been able to participate in person. Therefore, we plan to offer at least part of the annual conference as virtual next year. Please stay tuned for details. Hopefully they'll be coming very soon about date and location. Also, check out the marketplace and enter the marketplace challenges. You still have about, 40 minutes to complete that at 12:30 Eastern today. The link on how to get to the challenges will be in the chat. Note that all the recordings of today's presentation, as well as those from the earlier sessions in this week, will be available on our website after the conference. If you have questions, please type them into the Q&A function below at any time during the presentation. The presenters will be back for questions and panel discussion following the presentation, the third presentation today by Dr. Iyer. In the interest of time, as I make introductions, I'll only do brief introductions of the panelists. You can learn more about them at oley.org//Oley2022. That's our conference website. That will also be in the chat. Also note that closed captioning is available. The transcript you see is auto-generated by Zoom. We're not typing this in, and we're not able to check or edit it. And it's also often very inaccurate, especially with some of these medical terms. So realize that that's auto-generated. If you need technical support or any other kind of support for today, please call Kathy at the Oley office. I'll give the number, but it will also be in the chat. That's 518-262-5079. Welcome. I'm so excited about this topic today. There were several conversations yesterday about even what is intestinal failure, and hopefully that will be discussed a little bit today and we can have a little bit of clarity. The first thing I'd like to do today, though, is to begin our program with some messages from some of our corporate sponsors. We recognize we couldn't put on any of the conference without their support, so thank you.
Hello, everyone. My name is Michael Medwar, and I'm the patient advocate for Quorum's Nutrition Support Program. I'm here with my colleagues, Karen Hamilton, Director of our TPN operations, and Janelle Flaherty, Manager of our enteral dietitian and Medicare qualification teams. Karen, what are the biggest trends and issues you see for HPN consumers and providers, and how is Quorum addressing them?
Thanks, Michael. I'd say the biggest issue is supply chain disruptions and the resultant parenteral nutrition component shortages. Really, of all types, they've been persistent and increasing. At Quorum, our solution is to maintain a dedicated team of pharmacists, dietitians, and support staff to provide direct clinical care to our home parenteral nutrition consumers. We track product availability and identify appropriate substitutions for each and every patient. Our consumers who have prescribers who may not specialize in TPN, we have a home nutrition support team that provides specific recommendations for safe, effective nutrition care. Our team monitors labs and tolerance to therapy and works with the prescriber to make adjustments so consumers can achieve their goals. Quorum is here for you, even when there's supply chain bumps in the road.
Janelle, what do you see in enteral?
Similar to parenteral, supply chain disruptions and shortages are increasing. Quorum carries a large selection of enteral products, which helps provide flexibility to ensure consumers have alternatives. We have a team of nutrition support dietitians who work with our enteral consumers and prescribers to find the best solution available. Another trend is advancing technology. Quorum now offers multiple ways to order monthly supplies. Consumers can receive refill reminders by text or email and place orders online or by phone. As consumers start service with Quorum or have questions along the way, our dietitians are available to assist by phone or video chat to teach how to use supplies or troubleshoot issues.
Thank you, Janelle and Karen. To consumers and caregivers watching, Quorum is here for you. We continue to provide enteral nutrition services across the country and services such as TPN in many markets. For more information, see quorumhc.com or email me at the address on your screen. And enjoy today's programs.
My daughter has been on parenteral support overnight for a very long time. For us, it took 4 months to see any results. It was frustrating, and there were many times that I wanted to quit, but we kept going. And when we started to see results, we were happy. When starting Gattex, her doctor did tell us about the potential benefits and risks, such as more serious side effects like making abnormal cells grow faster and bowel blockage. Together, her doctor and I made the decision to start my daughter on Gattex, and I'm glad that we did, as it's helped her wean off of PS. And it's made a huge difference in our daily lives and just our ability to have some freedom in the evenings in particular. We've been able to spend more time doing things we love, like traveling and going on vacation. This is just our experience, and everyone's may be different.
Thanks again to our corporate sponsors for your support. Again, we really couldn't do this without your help, and we thank you for being here for us. Now I am pleased to introduce Swapna Kakani. Swapna is a sought-after professional speaker and an award-winning patient advocate in the area of healthcare delivery and the patient experience. Also a friend. Swapna, thank you for being here today to share your story.
Thank you, Beth. I'm going to share my screen and get started. Hi, everyone. Thank you for inviting me to speak today. It is always a pleasure to speak to the friends and family, peers, and professionals that are part of the Oley Foundation and who attend the Oley conference. Today, I'm going to be speaking about my journey as a patient advocate and a little bit about my own patient story because it really drives and it influences the purpose into my advocacy. My disclosure for today's presentation is that I am a consultant for Lift Echo. Lift Echo stands for Learn Intestinal Failure Tele-Echo, which I'll talk about briefly later in the presentation, and Dr. Iyer and Dr. Winkler will also talk about. My story starts 32 years ago when I was born with short bowel syndrome in 1989, actually almost now 33 years ago next month. I was born with a congenital defect, intestinal atresia, and at 2 days old, I had immediate surgery to get rid of the bowel that had atresia in it and connect what was remaining and leave me with some ostomies as well as central line and feeding tube. And at the time in 1989, the literature for TPN, long-term TPN, wasn't great. The prognosis was really unknown, and it was actually the physician that said, you should take one day at a time, and that is exactly what we did. Really appreciating each day and each milestone that I was able to hit, but really understanding that this is a journey versus really have a marker of milestones. And with that, we developed our own normal, which normal is different for everyone. My favorite quote about normal is just a drier setting. So I developed my own normal, and so for me that was being on TPN for the last 29 years of the 32 years. I have been on TPN anywhere from as minimum as 3 nights a week to as many as 7 nights a week, getting it nightly, 8 hours a night, 12 hours a night, 16 hours a night, getting some of my calories from it or all of my calories from it. I also have received enteral nutrition or tube feeding through a gastrostomy tube since childhood for about 25 years, and 20 of those years have actually been for feeding. So I would go to school just like my peers, but with my tube feeding backpack, and it looked exactly like it looks on the right and the inside, and then we outfitted it and customized it to match my desires, which was hot pink, Mickey Mouse stickers, etc. And this is kind of me, an epitome of me in childhood, which is sitting outside, headband, watch, and eating chips, salty chips. If I were to eat anything, I was going to eat salty chips. I ate like a bird. I didn't eat much. I would eat the same food or drink the same drink for hours at a time. But we all, as a team and as a family, we knew the importance of exposing myself to food. Although I may not have eaten much of it, I even sometimes pretended to eat and fooled a lot of people. So most, if not all, my calories came from the tube feeding and the TPN. So in 32 years, I've been on TPN for 29 of those years, and have had 31 central lines. Of those 31 central lines, 27 have been infected with bacterial or fungal infections. Last year, almost a year ago, last July, I had a central line infection after almost 15 years of no infections. And unfortunately, it was in the track. We had to take the central line out. We tried to save it, but we ended up having to take it out. And when we took it out, we learned that that was my last access point in the neck, and both sides of the neck. So I'm no longer on TPN, and I no longer have a central line, and it's been a little over a year. In those 32 years, I've had many central line placements, many abdominal surgeries, complications, and more that have resulted in a total of 67 surgeries. Though as recent as 2 weeks ago, I had surgery. My care has spanned across 10 different hospitals in the US. Some of these hospitals were used for consultation for subspecialty care and trying to seek right care at the right place at the right time. This is something that I learned late in life, I think, in my 20s, but is so important in the rare disease journey and in the short bowel syndrome intestinal failure journey. But it is so hard to achieve. When I transitioned from pediatrics, I was referred to an adult subspecialty center about 12 hours away from home, and we did gut rehab as much as we could, and then we were offered surgery, and as a team we agreed to go with surgery, and unfortunately had complications, more surgeries at different hospitals, more complications, which were fistulas. I ended up having fistulas between my small intestine, large intestine, skin, and bladder. I was miserable. I was raw both inside and out. I was depressed. I had bile leaking nonstop. I left college, and we really didn't know what to do. And so we learned the hard way. We had to put my health in our own hands. And as a family, we traveled across the country, 12 hours to cold country, 12 hours to the beach and more, seeking subspecialty care. And we realized that we were fortunate as a family to do that, but also if one place was not the right option, we could continue to seek options. And that's not always the situation. In searching for right care at the right place at the right time and getting advice from multiple providers, we made the hard decision of taking out the small intestine that I had fought for my entire life up until that point. And then I was dependent on a G-tube to gravity drainage, no food by mouth, and I was completely dependent on TPN and IV fluids for almost 3 years. It was then that I made the hard decision to have a small intestine transplant almost 8 years, more than 8 years ago now. At the time, my health, it was either staying the same or getting worse. There was no moving forward. I had exhausted all my options. And for me personally, I wanted to move forward and I wanted to exhaust all my options in the journey of short bowel syndrome, even if that meant the risk of death. I made the decision to have a transplant. And now 8 years later, I've had a lot of highs, including getting off TPN, getting back on TPN, and now getting back off TPN. But things that probably I'm more grateful for are no pain before, during, or after eating. I have solid stool some days, and I can eat more than I have ever eaten in my life, which is still very little to the average person, but that's okay. Again, my normal. But I also still have symptoms, and I say that I have short bowel syndrome until the day I die. I may have very mild short bowel syndrome now today, but because I don't have a colon, I have an ileostomy. So my main symptom is diarrhea, and I do have to be very diligent on hydration as well as, of course, nutrition. But in midst of the highs, there have been lows. Transplant is not a cure. It can be an exchange of hardships for some. I'm not going to go through each complication, but these are the complications that I've experienced in the last 8 years. One is the post-transplant lymphoproliferative disorder, PTLD, which is a rare disease in itself, and it is a type of cancer that is seen post solid organ transplant or post stem cell transplant. Most of these complications are listed in literature or are known as complications post transplant. Other thing I wanted to note is avascular necrosis of hips and shoulders. So avascular necrosis means avascular, so lack of blood supply. to the joint, to the ball of the joint, and the ball of the joint starts to collapse, unfortunately, or necrotize. And so the only long-term solution is for the AVN etiology is bilateral or hip replacements, joint replacements. So I've had bilateral hip replacements at the age of 26, and then just 2 weeks ago had my first shoulder replacement. And then post-transplant, as a family and as a team, we learned that I never truly learned how to eat. The surgeon said, "We fixed you, go and eat." And it was a shock to all of us that I had a really hard time maintaining the regimen, as well as being able to intake enough calories to rely on oral nutrition alone. And so I lost a lot of weight, got very dehydrated, and had to get back on TPN and IV fluids and maintain that cushion to be able to have physical, mental, and emotional energy week to week until last year. And we transitioned to G-tube feedings instead. And thankfully, I have surpassed the volume and rate that I had as a kid that we always struggled with, and I've been able to succeed on G-tube feedings as well as oral nutrition, with the understanding that I am meeting with a dietitian that focuses on restrictive intake. She usually meets with people that have eating disorders. Although this is not an eating disorder, it is a type of disordered eating that can come from the journey of intestinal failure, short bowel syndrome, long-term tubes and IVs. And so it has been a journey in itself working with this dietitian in terms of learning how to eat with the anatomy and symptoms that I have. The other thing we learned post-transplant is, of course, I'm a complicated case. I am, and I will be. One of the first, probably, I would say, advocacy efforts that I took on, that was the most personal advocacy effort, was finding the right provider. And I don't live at the transplants. I don't live in the city where the transplant was, and that's the case for many people. And so I had to learn how to work with the local team as well as the transplant team, and quickly found that I had a lot more needs that were beyond the scope of the intestine and transplant. And so I took it onto myself to find the pit crew. And so today, this is our multidisciplinary intestinal failure team that we're proud and happy to have. But as you can see, they are all over the US. Some are private practitioners, some are part of multidisciplinary intestinal failure gut rehab teams at academic university centers. So I'm going to talk more about the advocacy part of this journey, but I want everyone to understand this is all parallel to living life with short bowel syndrome and dealing with the side effects of your health as well as complications, but advocacy is always part of it. And I think it's an innate part of all of us. My really light bulb moment in advocacy truly came after the transplant, because I had the transplant at 24. So I was in my early 20s. It was the first time I really was taking ownership of my own health. I was no longer sitting quietly in clinic and my parents were answering most of the questions. I at 24 could finally articulate my own medical journey and understood most of everything. So I was taking on more ownership, and in return, really started noticing the healthcare arena and noticing how the patient voice wasn't being heard like I wanted it to be. And I thought we could do better. So after the transplant and in the recovery, I was trying to find, what do I do with my life? I'm 24. I had finished college right before the transplant, and in hopes, if the goal of any surgery we do to improve patient outcomes is for the purpose of patients, ourselves, to live our life. So how was I going to live my life? And I thought, well, let me volunteer first, because I don't know what my stamina is like, and I don't know what I can do. And so the first thing I did was outreach to people in our own network at the Oley Foundation. It was a mother of a peer who was my age, and she, I knew, was already in advocacy. So I reached out to her, and she gave me some tips and told me where to think about jobs, where to internship. And so I started reaching out to those individuals. And eventually, I had different opportunities with different organizations. And the advocacy journey has evolved in different ways. As you can see just from these pictures, some have been patient advocacy recordings about central line infections, minimization of central line infections. Another one is going to Capitol Hill and speaking on policy. And another one is giving keynotes at patient experience conferences on healthcare delivery, patient experience, pros, the positive stories, as well as what can we learn from some of the negative stories. So I'm going to go in more detail of how that came about. But first, these are kind of my tenets of advocacy. I'm calling them approaches to advocacy because tenet seems like a very strong word. But I want everyone to understand that advocacy comes in many forms. What I describe in my own journey is just some ways of doing advocacy. For example, I don't talk a lot about blog writing or publishing narratives and things like that, but that's a form of advocacy as well. If you take anything away from this, please remember you are your best advocate. It's surprising how few times we share that with others. Nobody ever told me that growing up. Nobody ever told me that as I started going into advocacy. But it's true. You know your story best. You know your experiences best, and that's really valuable. You don't have to be an advocate at all times, all places. So a lot of times there's seasons of advocacy. Before the pandemic, I was traveling a lot, speaking a lot. I was doing more advocacy than I am now. One, because of the pandemic, but also because of my health and other reasons. And so that can ebb and flow as it matches to your own journey. And so in the same vein, your needs, your desires in advocacy, the niches you have, that can evolve. The satisfaction you have in advocacy, that can all evolve as your journey as a parent, caregiver, patient, loved one, etc. progresses. And I've found that personally for me, and I know for others, advocacy in whatever way it is can be a form of coping. If you are interested in getting into advocacy, I have people ask me, how did you get involved? How did you get started? One is speaking up about your desire to get more involved. And that is to the Oley Foundation, that is to me, that is to other peers, whoever you are talking to. I really believe in speaking out loud what you wish for. And you would be surprised what other people will take from that. But also research what other advocates are doing, other organizations are doing, how they're doing advocacy, how they're writing, what they're talking about. Is that something you relate to? Or you say, hey, well, that's a great narrative, but they didn't think about this side of it. I can offer that side of it. And connect with one another. I've learned a lot from different peers, and I hope I've been able to advise peers who've come in contact with me. Advocacy perpetuates advocacy. When you get started, when you start doing things, the space is small and big. So people recognize when someone is speaking up and presenting or advocating for policy or finding their niche, and they will reach out if if they start seeing that you are showing up and doing what you desire and wish for. And then lastly, and again, if you take anything away from this, is advocacy is fed by grit. And what I mean by grit is, yes, perseverance, but perseverance for the long run. It's not a one and done. Unfortunately, healthcare advocacy, the healthcare arena is really built to drain a lot of us who are participate in it. And I don't think I think everyone knows that in a way. And so it really does require perseverance, and you will be discouraged. But to remember, this is a marathon. This is for the long haul. I may present today, but it's really the foundations, the connections, the networks, that we're creating month to month, years to come, to then maybe see a policy come forward years from today, or a system change months, or hopefully months from today, or years from today. So the first thing that I started with when I started getting more involved in one form of advocacy, and that was legislative advocacy, was working with what I had. So as I said, I went to a peer who was a mother of a son who has intestinal failure, and she connected me with another organization to possibly intern or volunteer. So I reached out to them and told them what I am able to offer. And at the time, I had organization skills, and I could maybe make an agenda, gave some very simple things I could do. Well, it turned out into a very big thing. So I ended up going to one of their patient conferences in a nearby city. And I actually asked if I could help, but also if I could speak at one of their events, because that's also what I was very interested in doing. And instead they said, "That's great, but we need you to organize a state house advocacy day. We're now doing that in every state." And I had no idea what that was. I had never been to our Capitol at the State House. I've never been to the State House at our state Capitol. But I said yes. I said yes. So the left picture is us doing the event, and I knew how to use social media, and I knew how to use email. And so I created an agenda, and I sent it to the emails they had given me and just blasted it on social media. But I had no idea how to work with legislators. These two legislators were the only people who showed up. Little did I know that the lady on the right is the chair of the health committee and a very important person in our legislature. So fast forward to the next year, we were able to expand it because I was able to learn from what I did the previous year. And then fast forward another year, we're passing policy with that legislator. We also partnered with different universities in the state to host a symposium, all from starting with what I have and networking. The other advice I got was connect with national organizations and conferences. And so these are a few of the national organizations in the rare disease space, including the Oley Foundation. The Oley Foundation logo is conveniently in the bottom right corner, so I didn't repeat it. ASPEN is a professional society for providers who treat patients on parenteral and enteral nutrition. Global Genes is a rare disease organization, national rare disease organization. NORD, National Organization for Rare Disorders. The Every Life Foundation is a rare disease organization. They host a rare disease week on Capitol Hill every year. And Patients and Providers for Medical Nutrition Equity is a coalition to pass policy for coverage of medical nutrition. And you may recognize Betty Marie. So when I connected with these national organizations, I made sure to ask questions and always offered, how can I help? Because I wanted to get involved. And again, advocacy perpetuates advocacy. And then now it's become a process of keeping in touch with different organizations, helping them in different ways. I now consult with certain entities and organizations, but essentially I'm never stopping advocating, or I never stop advocating. And I met our Senator Doug Jones from Alabama, and he gave us this quote that I always love, and it says, "Keep up the advocacy, never ever stop." And as I said, advocacy is fed by grit. It is a long-term process. And so what motivates me to not stop advocating? Because it can be tiring. And as I said, the arena can be built to drain us at times. Sometimes we think of success as a policy being passed or that program being put forward, or whatever that end result was we wanted. We think if we get that, that's our definition of success, and nothing else is successful. So one was learning that that's not definition of success in advocacy. And I really believe that every effort that you put forward is a part of the success, and to keep at it. That is sending an email, speaking up, sending that message to a peer to ask, hey, can we talk? And or learning from others. I mean, any effort. And then the other one is, and this helps me the most when I get nervous in clinic situations or in healthcare situations where I need to speak up, but I'm scared. And I remember that at the end of the day, you have to forget my family, my brother, my friends, my peers. It is me. I have to look at myself in the mirror. It is me wearing the TPN backpack, wearing the enteral nutrition backpack, living with short bowel syndrome, intestinal failure. Did I do everything in my control in regards of advocating or speaking up? Okay, and I know this slide is an oxymoron, but it's purposeful. There's a purpose. So one, in advocacy, a degree of any kind is not necessary. Again, as I said, your story, you know your story best, and your story is valuable. Your experience is valuable. That is the basis, I believe, of advocacy. Now, in parallel to this advocacy journey, I got a master's after I felt better post-transplant. I went back to school and got a master's in public health and healthcare organization and policy. So why? So as a career, I started figuring out and realizing that I really did have a passion in changing systems from a national or global level. And I really wanted to change the healthcare system. I did internships at the hospital, and they would say, "Oh, what do you want to do in your career?" And I would look right at them, these nurses, and say, "Oh, I'm going to change the healthcare system." And they would just have eyes, deer in the headlights look, and kind of laugh. I didn't get it at all. I didn't understand. I said, of course, I'm going to change the healthcare system. Now I understand. So one, it is very complicated. There's niches to the healthcare system, but two, as a mentor has told me, a healthcare is not a system. And I say that with utmost respect of everyone who's part of healthcare, including myself. And that is because when we have stress to healthcare, it can fall apart, as it can with our disease journey. But what I realized is, and learned through my experiences, is a lot of times to create change in healthcare, you have to show the evidence, evidence-based change. So let's say there's they want to implement a new program at the local hospital. A lot of times they need to see a pilot program or something that shows that this will work in their hospital. They want to see data. And I wanted to be part of creating that data, doing the research, and providing the evidence to make the change. And I wanted it to come from the patient voice and the community. So I got passionate in community-driven research and healthcare organization, and then I brought in my experience with healthcare policy and made that into a master's in public health. So that is how I got into the Lift Echo project, which I'm going to talk about briefly. And again, Dr. Iyer and Dr. Winkler will talk about more. So I was familiar with Echo and telemedicine because of the journey that I had trying to seek subspecialty care from all over the country, and really missing and not understanding why telemedicine cannot have been utilized. And this was all before the pandemic. I was at the conference where Dr. Iyer presented the launch of Lift Echo and immediately chased him down and asked if I could help in any way. You may not appreciate, but at the time he said, not right now. But then later on, a couple years later, this year, he reached back out. And there is now a grant that we have applied for to study the Lift Echo model, which is a virtual online platform of multidisciplinary providers who are engaging in helping manage intestinal failure patients by reviewing cases, as well as hearing didactic presentations. And the website is below, and you can browse it. It is designed for the provider. So we want to see if this model of teaching providers management of intestinal failure is actually improving patient outcomes. So my role in the project is to make sure the patient voice is incorporated in the study design, and the patient is included in as active participants, and that we do have patient engagement, and we make sure we disseminate our findings in a grassroots manner as the findings come. They're not there yet. We haven't started just yet. And we have goals of hopefully improving Lift Echo or designing Lift Echo in a way where it can be more patient-facing, hopefully someday. And the last advocacy research point I want to talk about is the gutsy perspective. And so this is a community-driven research initiative to study quality of life in the short bowel syndrome patient and caregiver population that we started. It's led by 3 parent advocates who are also researchers, as well as 1 community leader and myself. Our PI is Dr. Mercer. We have an advisor also from in Omaha. And we do have an industry grant just for the research part. This is a quite novel initiative because traditionally quality of life research, at least for pediatric short bowel syndrome patients, has really been focused on limitations and ill-being versus well-being, and what can we do versus what we cannot do. And up until this point, there has never been a tool that has been created a quality of life tool created specifically for the short bowel syndrome population. So as you can maybe imagine, the use of generic quality of life tools don't always assess adequately the experiences of somebody living with short bowel syndrome. And then with the gutsy perspective, we're making sure this is community driven. So we are building a short bowel syndrome quality of life survey to align with community priorities, and by using both quantitative and qualitative data. We did an exploratory study with the stakeholder committee, which were parents in the short bowel syndrome community last year. And we published those findings in the Journal of Pediatric Surgery last October. It'll actually come out in print in September. And you can this is a summary of some of the findings. This is also on our website. In light of time, I'm going to move forward. But we also have our website, thegutsyperspective.org, which you can review all of this, read the article, and I hope you do. But right now, there's 2 projects that you can very much get involved in that we would love for you to get involved in. And that's also a form of advocacy, especially in terms of really hearing the voices of kids and teens with short bowel syndrome. Because the tool is a pediatric quality of life tool, we want to hear from kids and teens with short bowel syndrome. And they will be able to hear about their experiences with short bowel syndrome. They'll be able to meet others in their same age group through the focus group. The focus group will be led by Marie Newman, who is a parent of a child with short bowel syndrome and a researcher, as well as Megan Raoun, who's the director of the Global Gastroschisis Foundation and a licensed mental health counselor. You can go to our website to sign up. We are really in need of teenagers 13 to 17 years old. And then we just launched today our Short Bowel Syndrome Awareness Month Gutsy Secret campaign. So you'll see that on social media, but these are some examples of some secrets that have already been shared, which are people sharing some of their innate or internal thoughts when coping with short bowel syndrome. So we'll have a collection of all the photos at the end of the month for you to see. With that, thank you.
Thank you, Swapna. You certainly spurred a lot of conversation over in the chat, and it was just going the whole time. People, wanting to advocate and saying, thank you for sharing, because it certainly means something for me. And one person said, now I don't have to feel like I can sit around and just be sick all day. I'm highly paraphrasing. There's some other ways I can get involved. So to me, that's a huge definition of success. So thank you for sharing. For those of you who would want to ask some questions for Swapna, we'll have some time at the end, towards the end during the panel discussion, to speak with her. So thank you so much. We'll see you in a little bit, Swapna. Next, we move to Marion Winkler, PhD and RD, who will be discussing the quality of life of home parenteral nutrition consumers. Dr. Winkler is a professor of surgery at Brown University Alpert School of Medicine and a surgical nutrition specialist in the Department of Surgery and Nutritional Support Service at Rhode Island Hospital in Providence, Rhode Island. Dr. Winkler, thank you so much for sharing with us today on this extremely important topic.
Thank you. I'm delighted to be here. Let me just bring up my slides. And I want to tell you that I'm sitting in a very cold office, so I hope I don't shake while I speak. Let's see, why is this not? Oh, can you see this in just the slides, or is it just showing up in?
We see disclosures. We see disclosures right now.
Okay, but you don't see the little boxes on the side. You just see.
Yes, we do. If you
Oh, I have two screens here, so that is the problem. Let me see how I do this. I am sorry about that. I have it in slideshow, but
if you may need to stop your share and share the other PowerPoint image.
Okay. Aha, you got it. No, still not working.
Nope, this is good.
Oh, you see it now?
Yeah, it's right now. You just have to.
Perfect. Okay. All right. So I am going to speak about quality of life and intestinal failure this afternoon. And first, I want to thank Swapna. And many of you know that I have been studying quality of life for most of my career and researching quality of life for most of my career. But where I have gained the most knowledge is from interacting with all of you. And I've been blessed really to have gotten to know Swapna and many other patient and family advocates over the last couple of years in some of the work we've been collaborating. So hopefully I'll share some of that as well. But today specifically, I plan to speak about a home parenteral nutrition patient-reported outcome questionnaire that you and your clinicians can use to start a conversation about quality of life. And I spoke about starting this conversation on the last 2 days of the conference. So I'm going to try not to repeat the same information, but I refer those of you who didn't have a chance to see that presentation to perhaps view that as well. And I also want to share how we plan to use this questionnaire in the Lift Echo outcome study, research study that Swapna just introduced to you and that Dr. Iyer will also speak about. Okay, so let me first talk about what are patient-reported outcomes, PROs. And I want to make sure the slide is moving, yes?
No.
No. I am so sorry. We
It's
should have
okay.
tried
You're
this.
on your disclosure slide still.
Yeah, I see that. There we go. How's that?
Yep.
Okay, great. Thank you. Sorry. Patient-reported outcomes are basically information that patients believe is important about their health. And in the published literature and in many outcome measure tools, these tend to address things like pain, sleep, sexual function, gastrointestinal symptoms, psychosocial impact, and social support. But really, it can be what matters most to you. And a lot of different questionnaires are being developed to be used in healthcare, again, to address these topics and stimulate conversation. Very, very frequently, patient-reported outcomes include health-related quality of life. Oftentimes, they address patient satisfaction with treatment, compliance with medical regimens, and end results of healthcare interventions. And examples of that might be pertinent would be changes in weight, blood pressure, laboratory tests, just to name a couple of different healthcare outcomes that we're oftentimes interested in. My interest in patient-reported outcomes and embracing quality of life for intestinal failure and home parenteral nutrition really is about improving clinician and patient communication and further advocating for shared decision-making. So that's really the standpoint for which I come into this. So let's start by talking about quality of life and HPN. And I spoke the other day that there are many definitions of quality of life, and everybody really should think about your own personal description of quality of life, but they tend to center on enjoyment of life, being happy and satisfied with life. In my research of adults living on home parenteral nutrition, the majority of whom have intestinal failure, short bowel syndrome, and some with dysmotility or pseudo obstruction, I began this journey of researching by doing what are called semi-structured interviews with individuals. And this is qualitative research, very patient focused. And what I asked were basically open-ended questions. And then I looked at all of the different responses, and I did this on telephone. So I had audio tape recordings. And then I listened across all of the interviews and tried to capture the themes that were similar and perspectives that may have been different. And so what I'm going to share is just some of the themes that arose from this interview type of work. But basically, in this population, quality of life was defined as how much one enjoys life, being happy and satisfied with life. And it was very much associated with being able to do what I want to do when I want to do it. And the things that people wanted to be able to do were to go to work, go to school, do household chores, attend church or other types of social functions, play or participate in sports and other leisure activities, travel, and eat and dine in restaurants. And the factors that influenced how much one enjoyed life and being happy and satisfied life with a positive flavor to it was having good health, having strength and stamina, having strong faith, family support, and financial security. And some of the negative factors were being in pain, feeling fatigued, having disabling and disastrous diarrhea, or ileostomy or ostomy leakage and high outputs. And many of these factors influencing quality of life for this work, I could group into categories. So as I mentioned, there were a number of factors around food and eating. And these spanned from eating to survive, to eating to stimulate health and immune system and intestinal adaptation, or learning to eat just for comfort or pleasure, or being in a social situation around food. And there was a whole range of how these factors influence quality of life positively or negatively. The gastrointestinal symptoms here play a huge role in the lives of people living with intestinal failure. There was also some very interesting findings regarding the HPN infusion schedule. And what I was able to hear in these interviews and capture was that there was groups of people who felt very structured, where their infusion schedule really dictated life, and they would tend to plan everything around the time frame they had to do their infusions. That would include maybe not going out at all, or cutting an evening short and running home, never really doing any adjustment of times or skipping. And then there was a group of people that I called flexible, that really learned to put their life first and their infusions fit into their life. And so they had a lot more flexibility in their start and stop times, and were more interested in taking it out with them and going on vacation. And we also know from recent published literature that the parenteral volume, either IV fluid and or parenteral nutrition, is associated with quality of life, both in terms of the number of days or nights of infusion, and starting to see a lot of that is based on the volume of the solution. So as volumes go down, or number of days or nights go down, quality of life goes up. So this is a whole interesting area of research being done now. Certainly, there was a lot about psychosocial functioning, mental health, and coping skills. And I found a lot of association around the topic of feeling prepared, well-trained, educated, and confident in being able to do the procedures that needed to be done. So these were the primary factors influencing quality of life. So what is the Home Parenteral Nutrition Patient-Reported Outcome Questionnaire? Well, this is a clinically relevant approach to identify and address lifestyle concerns of home parenteral nutrition patients that can be used in the medical office, or during a home care visit, or even in a telemedicine type of situation. It's different from a lot of questionnaires and quality of life tools because it does not compute a score that's used to compare to healthy populations or others, or yourself over time. It really is very subjective or qualitative in its approach. And we designed this to be a conversation starter. So it's like a self-assessment, and it helps prioritize important lifestyle issues that can be discussed with the physician or clinician. And in the research that we've conducted, we've done a lot of validation work among individuals who are on home parenteral nutrition, also with clinicians, physicians, dietitians, nurse pharmacists, and patient advocates in terms of the relevancy and importance of the items on the questionnaire. And then we administered the questionnaire to do some validation work in collaboration with Dr. Charlene Comfort at the Hospital of the University of Pennsylvania, in which we were able to demonstrate that this tool was sensitive to differences among individuals who had chronic intestinal failure or acute intestinal failure. And this does, we believe, improve clinician-patient relationship, another factor I really want to study, because a patient can share how he or she is feeling and obtain immediate feedback. And so it does lend itself to providing a positive patient experience. So what's in it? Well, again, the content or the questions I'm going to show you are structured around the HPN infusion schedule, around education and training preparedness. It includes some questions about or reflections about GI symptoms. There's a section on psychosocial function and coping and the impact of illness and therapy on quality of life, plus a rating of quality of life, a self reflection on how you would rate quality of life. Now, this is a small slide on your screens. I'll give you a, it's posted, this questionnaire is posted on the Oley website, and I've included the link, but you can find it also on the website. And I'm certainly happy to provide it if somebody wants it. I'm going to show it to you broken down so you can actually see the items on it a little bit bigger. But the instructions are that the questionnaire is intended to help you identify areas of concern or problems with living with home parenteral nutrition over the last 2-week period that may affect quality of life or your ability to do the things you would like to do. And that these patient reported outcomes can be used, as I said, to prioritize what you would like to discuss with your physician or home nutrition support care team during your visit. So what I'm going to show you now are the results of the study we conducted with Dr. Charlene Comfort at the University, the Penn Home PN program. And these were 77 individuals with acute or chronic intestinal failure. So the first part is the importance of having one or more nights without HPN or having a shorter HPN infusion and being able to do what I want to do when I want to do it. And you can see that the rating scale is on a Likert scale, basically from not important to extremely important. And for this group of participants in this study, the majority really felt that these were very or extremely important. Now, I'll tell you is that we use this questionnaire in our practice. And I find a lot of times that patients that I work with don't even know. They're surprised when they read this question. They say, you mean I can have one or more nights off PN, or I can have a shorter HPN infusion schedule? And while this may not be appropriate for every single patient, and it may not even be possible, it is a conversation starter. And this is a really important conversation for people to have. We learn more about the life, and patients learn more about the, the practice or the areas that we take into account to help plan the infusion schedule. So this has really been an interesting dynamic. The second section here is all on training and preparedness for HPN care. And again, in this particular study, there was very strong agreement that people felt that they were well trained and prepared to do self-care for their PN therapy. They understood their need for being on parenteral nutrition, how to care for their line, the signs and symptoms of infection and dehydration, and what to eat and or what not to eat, who to call. They felt supported. And they felt very confident in their, there was an association with their training and their training and preparedness with their confidence in their own ability. So that was not surprising in that program because they have such a strong home PN program. In our practice, interestingly, I find a lot of times that people reflect that they don't really understand the signs and symptoms or some of the answers to these questions. And so it's an opportunity for us when we're reviewing this form and having the conversation to do more training, to do more education, to get more resources, to recertify in techniques and procedures. Again, a really good opportunity to address these things. And what I'm always worried about is the awareness of individuals in terms of groups like Oley or the Gutsy Perspective or Transplant Unwrapped or all the wonderful resources that are out there. So this is another opportunity to be able to introduce those resources. And there's much more variability in how well people agree or don't agree that they're aware of these organizations. Okay, the next section really addresses health issues. So about health limitations on what I want to do in my life, about sleep disruption or sleep due to the pump or due to urination. And Dr. Hassan Dashti addressed this the other day in his research presentation about the sleep studies and has used this questionnaire in some of his work, or at least some of these questions. And it also addresses how the diarrhea or the ostomy output interrupts life. And you see in the responses here much greater variation in responses because everybody is so individual. Their anatomy is different. Their disease state or health of their GI tract is different. How they are infusing and other health issues all may play a role and not necessarily that we'll see everybody having similar responses. And these responses may change over time and be very different by what you're experiencing. So using this tool to have a conversation over time at different encounters or different visits really is very helpful as well. Similarly, the challenge of coping with being on home parenteral nutrition has a lot of variation in response. And the support that people feel, feeling supported by their home care team, that tends to be strong in this patient population, and it may be different, and it may be an opportunity to have a conversation about what programs are out there or, what needs need to be met, resources, referrals, etc. And finally, there are 3 quality of life questions. So the first 2, and these quality of life questions, I might add, come from the quality of life questionnaire that's been used in some of the research studies and in a lot of publications that Dr. Janet Baxter in the UK developed. It's called the HPN-QOL, and it was the first therapy-specific questionnaire designed for this patient population. And it was modified as the short bowel syndrome quality of life questionnaire and used in a lot of the GLP-2 studies. So with permission, these 3 questions are included on our HPN patient reported outcome questionnaire. And so these first 2 talk about the degree that quality of life's been affected by the underlying illness or by the HPN therapy. And I want to say that this was intentional to not tell us the direction. So when you answer this question, you're talking about the effect. If quality of life has had a major effect, a moderate effect, no effect, a neutral effect on life. And so I always have to have a conversation with people when they fill this out to understand whether that effect is positive or negative. And so that is another opportunity to have this conversation and to really get a sense and understand how someone's feeling. And then finally, there's one question about how is your quality of life? And you can see the scale is poor, fair, good, very good, or excellent. And again, this people answer all over the board, and this changes, and it starts the conversation about, well, what factors are playing into this description of poor or fair quality of life versus good, very good, or excellent. And in this group, it was about 50-50 how the ratings were. So we did a lot of interviews around people using these questionnaires, both when it was being developed and after the fact. And here are just two representative quotes of what people felt. And I just read them off to you. One is, I think these questions are phenomenal. I think they nail it. Doctors don't ask these questions, but this feels so human and full of empathy. I really appreciate these kinds of questions. And the second, I think it's excellent. It gives somebody topics to focus on when you're at the doctor and you have many questions to ask, and then you go home and you remember you forgot to ask. So I think it's a great conversation starter to have patients fill it out and discuss it during the visit. So I want to just now shift into research that's using the HPN PROQ. And I want to qualify this by saying that the intent of the questionnaire was to be a clinical tool, not a research tool. But the questions certainly can be used in research studies, and we could look at the percentage of time that people answer the question one way or the other. So the first study that is being done that I'm aware of is one that we're doing that's been on pause during the pandemic, but this is basically just an observational study where we're using this in practice. And I have people who are trained to be observers. And we've done a few, so it's kind of like a pilot study, I guess you could say. This is qualitative in nature. And so the observer just really captures what they're hearing, what they're seeing, what the nonverbal communication is. And in the little pilot study we've done, we see more equal amount of time in speaking, like the physician and the patient are talking, and not dominated by the medical professional, which sometimes is the case in a regular office visit. We also see more touchy-feely kind of topics getting discussed, at least that's what I kind of talk about, rather than just, you know, lab tests and weight and you know, medical things. So this may be very interesting, and our interest here is understanding whether this does improve patient-clinician communication. The second I already mentioned was Dr. Hassan Dashti is using some aspects of these, the questionnaire in his research surveying home parenteral and enteral nutrition infusion times and sleep patterns. And finally, our plans are to use this in the research study that Swapna briefly mentioned and that Dr. Iyer will probably tell you about, the LIFT Echo patient outcomes and patient reported quality of life. So what our intent here is to demonstrate improved clinical outcomes and chronic intestinal failure and parenteral nutrition specific patient-reported quality of life by providing virtual multidisciplinary support to the physicians through LIFT Echo. And Swapna has told you briefly about LIFT Echo, the Learn Intestinal Failure Tele-Echo Clinic. This is an online community of medical professionals dedicated to supporting the treatment and management of intestinal failure. So these clinics really are twofold. There are practitioners presenting case studies of patients they're really taking care of, where they can get consultation with experts both throughout the United States and really all over the world. We have a big global and international presence. They can get treatment guidance. They can ask very specific questions and get guidance about that. Oftentimes there's treatment alternatives raised or discussed. And through this, there's education being provided to physicians and really the full multidisciplinary healthcare team. And always included, in addition to these case presentations, are very small 15-20 minute didactic or educational topics that are being presented. So I'm almost done, and I just want to tell you really what the question is here. The research question we're interested in is, does physician participation in this LIFT Echo improve physician learning? In other words, do they improve their knowledge about intestinal failure management? And the intent is really to try to capture or provide an education to physicians who may not be immersed in taking care of intestinal failure patients. Maybe they have 1 or 2 patients and could really benefit from this expert group providing support. So we can easily measure using pre and post testing and see if knowledge changes. But what's very exciting is whether there are changes in how the patient is cared for as a result of this education. So we want to know whether the patient clinical outcomes and patient-reported quality of life improves as a result of this physician learning. So the design is going to be where we'll have an opportunity to match patients to their physicians. The patients who are in this study will have an opportunity to share baseline demographic and clinical information. They would actually complete this patient-reported outcome questionnaire electronically or by phone several times during the study period. And there's also an opportunity to look at changes of an intestinal failure disease activity index that we're in the process of developing and validating. So how do you get involved? You can use this questionnaire. I've provided a link of how you can find it on the Oley website. And you can watch for announcements about LIFT Echo research study. And I'm sure Dr. Iyer will address that as well. And I want to just close with a reminder that, as Swapna said, speak up. Your voice is very important. And the areas regarding quality of life that are important to discuss with all members of your healthcare team, I believe, are your personal definition of quality of life and what factors influence it, your goals and expectations of your therapy, your expectations around food and eating, any difficulty that you have coping with your medical condition, health, or treatment, and really anything interfering with your ability to do what you want to do. Thank you. Oops.
Thanks so much, Dr. Winkler. It's always interesting. For the participants, you can continue to add questions down below in the Q&A section. Already some piling up there that we will address at the panel discussion section of this today. Our next presentation today is from Dr. Kishore Iyer. They've been mentioning him today, Director of Adult and Pediatric Intestinal Rehabilitation and Transplantation at Mount Sinai Medical Center in New York, New York. Dr. Iyer will be discussing LIFT Echo, a unique program that allows intestinal failure specialists to learn and to share their expertise virtually, in part by discussing individual de-identified case studies. Thank you, Dr. Iyer.
Good afternoon. I'm delighted to join this intestinal failure session at the Oley meeting to give an update on the LIFT Echo project that I hope some, if not all of you, have already heard a little bit about. Here are my disclosures. I'm a scientific advisor to several pharmaceutical companies, as you see there, an investigator with some of them, and have received grant support for research as shown there. Before I get into the meat of this talk, I want to acknowledge that the Lift Echo project, which really started as a labor of love, has been supported by pilot grants from the Rekanati Miller Transplant Institute and the Intestinal Research Fund at Mount Sinai, where I'm based, from your very own Oley Foundation, and from a generous seed grant from Zealand Pharmaceuticals in Denmark when we launched this project. We've also received a very generous continuing project grant from Takeda Pharmaceuticals that has really allowed us to push the application of the Lift Echo project and take it to where it is today. And I hope you'll agree that there is a lot of potential. Intestinal failure poses several significant challenges. As many of you know, it's a very rare disease with an estimated prevalence in the United States of somewhere between 25,000 to 40,000 cases, probably closer to the lower number. And that in itself says something that we really don't even know the exact prevalence at the present time. There isn't a specific diagnostic code for intestinal failure under the ICD coding system, the International Classification for Diseases. That will hopefully change in the very near future and things may improve somewhat. We know that the best results when we manage intestinal failure really require experienced multidisciplinary teams bringing different types of expertise to bear on a very complex problem. The ideal programs will have really some or all of a combination of gastroenterologists, hepatologists, surgeons, perhaps transplant surgeons, nurses, physician assistants, nutritionists certainly, social workers, and really several other specialists as needed on occasion. Not a complete surprise that for such a rare disease with such complex management requirements, there really are very few experienced intestinal rehabilitation teams around the country. Thus, there are problems of distance, of geography. We all know there are insurance constraints. Even if you wanted to go to an expert center, your insurance company may not authorize such a visit. Thus, there are difficulties in access, and the question arises, should the intestinal failure patient, say in Montana, have the same expertise, same access to expertise as the patient in New York or in Omaha? Is there evidence for this type of generalized lack of expertise? We know, and there is data for this, that most GI fellowship training programs in the United States provide very little specific training in home parenteral nutrition. Equally, these programs provide very little to no specific training in intestinal failure. So we then developed an overarching hypothesis that there is widespread lack of knowledge in intestinal failure care, and we will explore further what this lack of knowledge might lead to. But the fact is that there are no systematic studies of knowledge gaps in chronic intestinal failure, and we recently reported our experience attempting to study this issue. We identified 4 key components of home parenteral nutrition and intestinal failure that we thought constitute relatively basic expertise. We developed a knowledge test of 20 questions with 5 questions in each of these components. We did some internal testing, improved the questions, we got some feedback. We then revised the questions. We reviewed the test with 2 experts in survey construction and in intestinal failure to make sure the questions were easily understood, there was not any confusion, and they were relevant to what we were trying to test. Based on that feedback, there was further revision. We then identified a convenient sample of 20 experts in intestinal failure and 25 non-experts. And the experts were clinicians with extensive record of clinical and academic activity in intestinal failure. Non-experts were fellows in training, relatively advanced trainees in GI and hepatology and transplant surgery. And to try and correct for any impact of age and years of experience, we threw in some liver and kidney transplant surgeons into the mix who had no specific training in intestinal failure. We analyzed de-identified knowledge test scores from 16 experts and 22 non-experts who turned in the test. And you can see right away in the table shown there that the experts seemingly did much better than the non-experts in our test. And when we looked at statistical significance for those who are interested, these results were quite significant. And we looked at, is our test reliable? Do the test questions, are they measuring the same concepts? And without getting into the weeds, the results suggested that our test items were likely measuring the same concepts of broad knowledge in intestinal failure and HPN. Again, I don't want to spend too much time on this, except to say that this concept, this is what's called an ROC curve, and some of you may be familiar with this. But the idea is, if you look at the diagonal, the straight line going across the middle of this square, that diagonal is about the same as flipping a coin. So if you flipped a coin and tried to decide, is the person taking this test an expert or a non-expert, you'd have a 50-50 chance of getting it right, and that's the diagonal. If the test you're applying, it doesn't matter whether that's a COVID test or it's a knowledge test in intestinal failure. If the results of that test move towards the top left corner, the test gets better and better. And you can see that our test actually did quite well with a sensitivity of over 80% and a specificity of over 85%, suggesting that it was pretty effective at distinguishing between experts and non-experts in intestinal failure. Now that we had the test, we took it a step further. Many of you may be familiar with Medscape, an online health information platform that does a variety of things, including providing continuing medical education for clinicians. This is an important part of their work, not the only work that they do. And we've done some work with Medscape before, and they were interested in this project and agreed to help us. And with Medscape's help, we deployed our de-identified knowledge test now to 100 US gastroenterologists. And you can see there we had good participation from California, from New York, from Illinois, but really from a good part of the country, not all of the states, but 31 of the 50 states had at least one participant. And some of the respondents actually claimed to have significant clinical experience in GI, and some even that they were actually managing some home TPN patients. And then we later realized that this question was not completely clear. We should have asked them, were you actually prescribing the TPN? We didn't ask that. But anyway, that's what we got. 55 of the test takers considered themselves expert in parenteral nutrition. This may tell you more about human psychology than it does about intestinal failure. Every one of us is an expert. But here are the results of the Medscape survey. And if you're following what I've been saying so far, you'll see right off the bat that really people did not do well in this test. Of the 100 gastroenterologists, the overall mean and median scores, sort of average scores, were really below the level of, well below the level of our experts, no different from the non-experts in our earlier sample. And interestingly, as I perhaps alluded to earlier, the people who claimed they were experts did not really do much better. They did just as badly. And there are clearly some questions that we still have to tease apart. You know, We don't have a clear definition of who's an expert, who's a non-expert, but it does show that in a relatively well-validated knowledge test in intestinal failure and HPN, from a population of 100 US gastroenterologists, we did not find significant expertise really in anybody in that sample. And I must confess to you, and I wouldn't be surprised if I don't get too many greeting cards from gastroenterologists, but obviously this does not include any of my friends who are experts. This was not a surprise to me. This is really what I suspected for a long time. Our knowledge test and this survey confirmed the results, and we recently published this paper in JPEN. So what did we learn? We learned that knowledge of intestinal failure is poor, perhaps at the level of non-experts in this cohort. And it is even possible that people who are experts in home TPN may not necessarily be experts in intestinal failure. The two are obviously related, but they're not the same. I don't want to belabor the rest, but we do think that this supports prior observations, and we need to study this issue further. But so we've now got some evidence that there's lack of expertise. Is there evidence for geographical disparity? Now, we had the opportunity, and Dr. Manpreet Mundi, who many of you should know, really led this project that was supported by Zealand Pharmaceuticals from Denmark. And it was a very interesting exercise to look at a large population, a large US population for whom we had claims data from a very large data set. This was roughly 350 million health insurance claims. It was quite a difficult project that required significant effort to tease apart who really had intestinal failure, who was on TPN for how long. But I've just pulled a couple of figures from that paper. And if you think of this as a heat map that you might have sometimes seen, especially recently in the context of COVID, you'll see that there is each dot on this map represents a single physician who is signing orders for parenteral support. And the blue dots, which are the overwhelming majority, are physicians who are prescribing HPN for anywhere from 1 to 4 patients. And you can see that there's a very large number of blue dots. The red dots are the physicians prescribing HPN for more than 20 patients. And you can see that's a very, very small number. So if you think, and I'm going to spend a minute on this slide, if you think that there are about 25,000 HPN patients, and I'm rounding this data, there are actually about 12,000 prescribers for that HPN across the US. Simple math. Each physician, if you ignore the experts who are, say, prescribing for more than 20 patients, or even more than 10 patients, more than 5 patients, there's a very large number of physicians who are unfortunately having to prescribe PN for 1 to 2 patients each. And that's not a setup that lends itself to accumulating expertise. This was another interesting piece of data that came out of that study. Look at the distance that patients are having to travel to see their HPN prescriber. If you even forget, if you ignore the patients who are traveling over 1,000 miles, I don't know what that's about. Maybe they have specific physicians that they like, relationships with programs, and I can understand that very well. But even on the average, it appears that many patients are traveling anywhere between perhaps 75 to about 200-300 miles to their PN prescriber, and that cannot be a good thing. Do these disparities in access to expertise have any impact on clinical outcomes? I just want to emphasize that this data is unpublished. I'm going to be presenting it in Vienna at the ESPEN meeting coming up next month. But look at this. It's again a complicated graph. This is work that I had the good fortune to do, and we're continuing this project with a group from Optum, the very large insurance provider, if you like, the sort of corporate flagship of United Healthcare. What you can see here that is that roughly 50% of patients have less than one to two inpatient admissions while on HPN. This is for every 100 days of HPN. So for 100 days, just over 3 months of HPN, we think with intestinal failure, about 50% of these patients, when we looked at a 3-year period, had a maximum of 1 to 2 inpatient admissions, maybe 1 to 2 ER visits. And you'd say for a relatively sick patient population, that is pretty good. But look at the right half of this panel, and at the extreme end, there's about 6% of patients who have over 9 ER visits, emergency room visits, in about a 3-month period with intestinal failure. About 5% have about 10 inpatient admissions in a 3-month period. And you can see this is a very worrisome trend, that there's a significant percentage of these patients with chronic intestinal failure who seemingly are bouncing in and out of the hospital, in and out of ERs. And while some may be unavoidable and may reflect very sick patients, it does seem that some of this is perhaps related to lack of expertise. I will emphasize we've not shown a causal relationship yet. I can't tell you that lack of expertise is what led to this graph. That I can't tell you, but certainly the data at this stage looks suspicious. So, can we do anything about this problem of inequity in access to expertise? And this has been a question for those of you who know me from Oley. This is a question that I've been discussing with several of you over the years. We've certainly worried about this problem and continue to worry about this problem for our patients with chronic intestinal failure or on long-term HPN. While I was mulling over these issues purely by chance, I came across work that was being done by Dr. Sanjeev Arora on a project called Project ECHO. Dr. Arora is a liver specialist in New Mexico who was worrying about very similar issues, that there was really very little expertise in liver medicine. At various times, he was just one liver specialist in all of New Mexico, now maybe one of 2 liver specialists in all of New Mexico, and that was not enough to look after the growing number of patients with hepatitis C. And what he did was started a tele-mentoring program with a catchy but really very, very true mantra that he was hoping to improve clinical outcomes by moving knowledge, not people. And what he was trying to do was to connect multidisciplinary teams of specialists at the University Hospital in New Mexico with primary care providers at community clinics across New Mexico, with the idea of helping them look after their patients with hepatitis C instead of the patient having to come down to the university hospital. There are some principles of the ECHO model, the ABCDs, if you like. A for amplification, using technology, much like what we're doing now, using Zoom to leverage scarce resources. B is for best practices. This is sort of the gold standard in medicine. We would like to aspire to best practices. And one of the problems is there are not clearly agreed upon best practices in intestinal failure when we think about ourselves. But at least that's the idea in ECHO. If you share best practices, that can improve outcome. And the idea from C, case-based learning to master complexity, is a well-recognized principle in medical training. That's how all of us acquired specialist training. And finally, Dr. Arora emphasized that you really have to monitor outcomes. You have to use databases to capture what is it that you're doing, what is the impact you're having, and how can you improve. I want to emphasize here that the echo model is not the same as telemedicine that many of you may already be familiar with. In telemedicine, the one-to-one relationship between the patient and the physician does not change. All that is saved is that the patient, perhaps from the comfort of his or her own home, can dial in on some kind of virtual platform, see the physician online, and conduct an online consultation and get the opinion and treatment perhaps that he or she needs. Is increasingly coming into vogue in the context of COVID, certainly. And many of us are pivoting towards telemedicine. It's not always possible in all situations, but where we can, some follow-up visits, some HPN visits, we're able to do with telemedicine. In contrast, what ECHO does, as shown in the upper part of the panel, is that there's an expert team at a hub, say, for example, at Mount Sinai, and we have learners at different spoke sites. Those learners are clinicians who have individual patients they are either struggling with or have some questions about. And there is an exchange of knowledge and learning between the expert hub team, and you can see this as a hub and spoke model. But keep in mind, this is not really, somehow this is not a hierarchy of learning what we and others doing ECHO projects are learning constantly. It's really an all teach, all learn model. There are different things that people out in the community who are looking after patients under sometimes difficult conditions can teach the clinicians who have the benefit of looking after patients in larger academic programs. And ultimately, the hope from ECHO is that patients will actually benefit from this exchange of knowledge. So this was our first ECHO for intestinal failure. Those two pictures literally are the very first ECHO project we did. And the line drawing above it is how an echo works. We do it over 1 hour. It's literally like a 1 hour virtual grand rounds. These grand rounds are academic meetings that happen in teaching hospitals all over the world. And the way we run our echo is somewhat similar. There's a 5-minute introduction, some housekeeping, and somebody signing in on Zoom presents a case. Keep in mind, no patient details, no specific patient identifiers are shared. This is what's called HIPAA compliant. There's complete patient confidentiality. We don't know the patient's name. We don't know where he or she is living. All we know is that this clinician has a patient that he or she wants to present and discuss and get feedback, and sometimes we'll provide summary recommendations. And at the end of the case presentation, we have an expert speaker from somewhere give a presentation, much like I'm doing today, a 20-minute presentation on a topic of interest to intestinal failure. So we launched this in May of 2019. The physical host is at Mount Sinai, but I want to emphasize that's really all that is based in Mount Sinai. We have an expert medical advisory board. We have people signing in who are experts from all over the US. We're maintaining fidelity to the original ECHO model. We're supported by the ECHO Institute in Albuquerque. Right now, we're doing 2 adult clinics per month. We added a pediatric clinic that's run by my colleague, Dr. Joanne Lai. I say recently, but that's now already about 2 years. I want to leave that website there for a minute. All of our didactic videos are archived for later viewing, and those didactic videos are open to anybody to see. While the Lift Echo clinics right now are open only to clinicians who have to register, you can feel free to go to our website. It's a little difficult to find. We are revamping our website to make it easier, but you can go there and you can hear. Right now, there are about 100 20-minute presentations, really bite-sized presentations on a variety of topics on HPN, intestinal failure, GLP-2, transplant, surgery, what have you. Very quickly, how have we done? Certainly in terms of attendance, it's steadily increased. When we do it in modules of 8 sessions each. The first module, we had 44 participants by the time we finished our 6th module, and we're probably now up to the 8th or 9th module. Our 6th module had an average attendance of 159 sites per session, and you can see the number of participants on the right is pretty significant. We have a pretty steadily growing geographical reach across the US. We're now getting participants from 42 states and District of Columbia. We have a lot of international participants from 6 of the 7 continents, technically all 7. We're trying to figure out who's looking after intestinal failure in Antarctica. And there's a mix of disciplines, which is how it should be. Intestinal failure is patients are best looked after by multidisciplinary teams, and our attendance reflects that. I'll tell you, I said that all our didactics are archived on our website. We don't know who is looking at them, but we know how many people are looking at them and how well they're looking at them. Yes, Big Brother is watching you, so please make us happy. Go to our website, look at the didactics, and educate yourself. We have reported our initial experience with the Left Echo project. This is important. Grant-giving bodies want to see this. And we have several upcoming projects where I am presenting in Vienna next month. We've done a knowledge survey on intestinal failure among European and British gastroenterologists. Yes, Britain is no longer part of the EU. We've just completed a survey of ASPEN members to look at knowledge among nutritionists. So those will be published in the near future. We're just launching a pilot project with the American College of Gastroenterology. This will go live in September. And our idea here is this may be our first opportunity to measure knowledge of ACG members at baseline, have them go through Left Echo, then do a knowledge test at the end of Left Echo. And we want to see, can we improve knowledge? Can we make this knowledge enduring? And we're also hoping we'll stimulate some interest in our field that may hopefully have some workforce implications downstream. There are some important upcoming projects, and this presentation today is our first attempt at trying to keep you up to date with what's happening with Left Echo, because we really want to increase patient engagement. There's a major project that we are getting ready to launch in partnership with Optum Home Infusion, and I want to give a shout out to my friends and colleagues, Penny Allen, Maria, Karim Bakas, that many of you know, Kara Gallagher. They've been really great and very responsive partners in our research effort. Unfortunately, we didn't get funded in the last round, but we've been told we came very close. We've been invited to resubmit with some revisions, and that's happening in the very near future. So we hope to get some major grant funding to allow us to continue this work. But we really want to see, can we improve patient outcomes by improving physician learning in intestinal failure? We are, as part of this project, there's a very exciting effort to develop a new intestinal failure disease activity index. How do we measure? Are patients doing well? Are they doing badly? Dr. Winkler, Marion Winkler, many of you know, has done some remarkable work over the years on patient-reported quality of life, and we want to incorporate that in our research. And we want to offer Left Echo to interested clinicians. Initially, we're going to start this through Optum to demonstrate improvements in knowledge. So how can, where does Oley come in, and how can you engage? Oley has been a remarkable early partner in our Left Echo efforts. Joan Bishop and Lisa Metzger and Beth Gore came with us to New Mexico when we were first exploring doing this. Oley has continued to give us ongoing support with initially a small but important and significant seed grant, and really continued engagement. So again, I will say to you, those didactic videos are there for Oley members, clinicians, patients, family members to see. We would like very much, we're exploring how to do this, to roll out Lift Echo to Oley member clinicians at this stage. If you're a consumer or a patient, you cannot directly participate right now, but you can certainly advocate and push your clinician if you think he or she might benefit or may even be interested to participate in Lift Echo. And the big question we're now asking ourselves, it's not been done in any other echo project, can we launch a patient-facing echo in intestinal failure? I just overshot my time, so my apologies to the organizers. But I want to conclude by saying there appears to be a critical shortage of expertise in intestinal failure and HPN in the US. Telelearning platforms like Lift Echo may help attenuate these knowledge disparities, direct benefit to intestinal failure patients from improving knowledge levels in non-specialist clinicians remains to be proven. Thank you so much for the privilege of the floor.
Thank you so much, Dr. Iyer. I think this is such an important conversation, and I'm so thankful for people like you who are advocating on behalf of patients. Now I'd love to welcome back Swapna and Dr. Winkler. We would love to have had Dr. Iyer back, but due to some travel woes, he will not be able to join us live for this next session, unfortunately. But we're going to have an interactive panel discussion about how you can get involved in patient advocacy and engagement, and then also try to address some of the questions that are down below. So thanks back, Marion and Swapna. Thanks for having us today, joining us today. So there's quite a few conversations that have been happening in the chat, and then there's quite a few questions in the Q&A, but just really wanted to start with something pretty general. And I would ask this of Swapna is, you talked about, the power of using our voice as patients. Have you particularly seen like something that's aspects that are more effective than others, or are there things that, seem to be more effective that we do?
Yeah, I think not underestimating conciseness, but also like confidence in what you're articulating. That took me a while to understand and learn, but really being confident in your message and whoever you're speaking to, if that's email, if that's speaking, if that's writing on social media. I want everyone to be as genuine as possible, but do check your writing and read and how you're writing, because storytelling is so powerful in any medium. And so if you can get your message across with confidence, but with also being genuine and articulating it well, you can go really far.
I agree. So well said. And then I'm going to ask a quick question to Dr. Winkler. At first, I was at Aspen, and you talked about the shared some time frames. I forget the exact numbers, but like 0 to so many years and 10 plus years. I just remember that being really profound to me. Is there any way that you can just quickly share? You don't have to share the exact data on that, but just the essence of that. I thought that was so important to capture that over time our experiences seem to change.
So thank you for that question. I just want to add one last thing to the previous question, if I can, is if you're in a one-to-one scenario where you're going to share information or you have a lot of questions you want to ask, make sure at the very beginning of the encounter, you tell the physician or the practitioner you have questions so that they save time for you. So in my research, I had 24 people I interviewed, and I purposely recruited them based on their length of home parenteral nutrition dependency. So I had a small group that was less than 2 years, and this was guided by work done in or other research. So there was some I guess rationale for these categories of time is the best way for me to say it. So I had some less than 2 year people, some 2 to 5, 5 to 10, and greater than 10. And in the greater than 10 years of HPN dependency, there were 2 that were longer than 25. And so the people in the less than 2 years basically talked about their experiences compared to what their life was before their illness or their need for PN. And their understanding and expectation was that this was a temporary therapy and that anytime soon they might be having surgery or having something done that they would no longer need PN. In the 2 to 5 years, there was a beginning to understand that my life is different than it was before. In the 5 to 10 year group, there was this acceptancy in some ways about understanding the need for PN, establishing a new normal, like Swapna talked about, like some recognition that this is the way my life is, and I want to focus on what I can do and not what I can't do. In the longer than 10 years, there was obviously acceptance that this is my life, but it basically the longer time on, and especially the people for the 25 years, they felt like they were in uncharted territory because nobody could really tell them what was to come. So there was this, you know, I don't want to say concern, but there was a recognition that they really are going to teach everybody else what life is like with long-term survival on PN. So it was very, very interesting. But in my understanding of the literature to date, there is very little research looking at repeated measures over time to actually take the individual and study them over time and see those if quality of life changes. I hope somebody will do that.
Well, thank you for that. And I remember, thank you for sharing that again. I remember sitting there thinking, yeah, that was what I was doing at 0 to 2. And then you shift to 2 to 5. Well, yeah, that was my experience too. And then the same thing, like my son has been, has intestinal failure and he has been on PN for almost 12 years now. And it was exactly, mine fit that same thing. I don't know that everybody's will, but I found it quite interesting and I had never really considered that before. So thank you for highlighting that today. One of the questions is, or it's actually a statement, but I like to turn it into a question, is about how we could potentially even use this as an EN measure and not just PN. Do you have some thoughts on that?
Well, my work in developing this questionnaire was totally based on adults receiving home parenteral nutrition. And so the first phase of it was those interviews and then trying to capture the general themes that I was hearing. And then that established the framework for which to write those patient-reported outcome questions. So that, and then all the testing was done among adults with intestinal failure, although the population of home PN dependency gets broader as the studies were conducted and the validation work was done. So it cannot be generalized to pediatrics. It cannot be generalized to, say, other conditions that might require PN that aren't intestinal failure. And from a research perspective, it's not generalizable to home enteral nutrition, but certainly the questions can be modified and can be used. And I know that some of the people who are participating in this audience have a lot of interest in wanting to do that for different populations. So I think certainly the conversation can be structured around that with any type of therapy. But from a research standpoint, it's only been tested in that very narrow population.
I think it's an interesting perspective though. Like, for example, my dad has end-stage heart failure right now. And so I can look up some measures and say, hey, not all of these things might apply, but there's a, quality of life measures. This is probably the closest I've ever seen for, all things, not just parenteral nutrition. And so while she's saying for research purposes, it can't be generalizable, but that doesn't mean you guys can't print it out, take it to your doctor and help have that conversation with them. And it's the beginning of the conversation nutrition. We may not be able to use it for research at this point, the results. That's really what she's saying, but please modify it.
Yeah, and there are a lot of research is used with generic health-related quality of life instruments. So people may have things they fill out, but I think what we did learn in the last 20 years, the importance of disease-specific or therapy-specific tools, and as Swapna and the Gutsy Perspective projects are focusing on, from the grassroots up in trying to design that to capture the experiences that really people are facing. So I think that's very, very important. And in addition, there are other things. There's a coping well home enteral nutrition I don't know what to call it, a manual that was designed based on similar type of work by Dr. Cheryl Thompson. It's old now, but very valid. And that did focus groups and interviews with home enteral nutrition consumers. And she's got a checklist of all kinds of things that can be used. And I tried to incorporate some of that into the previously recorded talks.
Absolutely. Well, thanks for sharing that. And along those same line, while we're still talking about the tool, it says have you seen this tool as useful for helping clinicians learn to encourage the flexibilities patients need to have for improved quality of life? She says it seems that often those who are more conservative or restricted are reflecting the training and fears they've learned from clinicians.
Yeah, there's so many things in that question that it just sparked me wanting to talk about. First of all, when I first presented the data, clinicians said, if they found their patient was manipulating the times or changing things, that in many ways that gets interpreted as non-compliance. And I said, I think it is more flexible. And so I agree. I think there has to be a lot of clinician education about what can be done and how the therapy can better be incorporated into people's lives instead of the way we prescribe it or recommend it be done. And that is across the board in both parenteral and enteral nutrition. I often say that some of the administration and infusion schedules that we do in the hospital really are not conducive to doing at home, but we're kind of stuck in that medical model. So I think really it should be a conversation. And if the clinician whom a patient or consumer is talking to doesn't feel comfortable doing it, then I think that, there could be a recommendation is, well, could I get a second opinion? Could we talk about other people? Maybe you might want to talk with a clinician, another physician or clinician who I know is managing a friend of mine this way. So there's ways to engage in the conversation, even if somebody doesn't feel comfortable.
Absolutely. And I'm going to throw this question to Swapna in just a second here, but there's even things like, changing in the time of the year. Twice a year, we forward an hour and we back an hour and things like that. And that's never in the 12 years we've been on parenteral nutrition has never even been discussed of how do I handle that? Do I go up by 15 minutes every day and I'm there? Nobody's ever brought that up. I just figured it out on my own. Or things like we're about to go to surgery and it's, 10 o'clock in the morning and he's got a 2-hour ramp. Well, what am I supposed to do? And I've come up with some things that I'm supposed to do, but it's just, those are conversations that we need to have. And I quite bluntly, at least in my case, and maybe you guys have better teams than I do, no slight to the teams that I'm talking to, but they say, I don't know, talk to the next person, and they kind of pass it down the road. So Swapna, that same question to you, basically, what are some things that you've had to do, things that you've done on your own versus talk to your clinicians about, or what's that balance there?
So advocating, one of the things I've talked with Dr. Winkler about in terms of advocating, one tip I've learned in adulthood is, even though I speak for a living and do public speaking, I get very nervous in clinic appointments. It's intimidating to an extent. Sometimes there are situations where we're only looked at as patients, period. And it's unfortunate. And so I write everything down. And that piece of paper gives me the ability to talk, or like my notes, or I've even done a patient reported summary, but also including like my desires or the desire to have a team that works with consults or I need you guys to manage nutrition and hydration, but surgery is being managed by a different team, or this is the model that we have in place. This is what we need you to do. And I just say it bluntly. But that has come with time and interacting with different providers through the Oley Foundation conference, meeting the speakers who speak at these conferences. A lot of times there are the experts in the field. But then in terms of more personal day-to-day care, there have been a lot of situations where at this stage in life, I'm very much in the uncharted territory. It may be unique to the fact that I'm alive, having been born in 1989, and the history that I've had, but it's not unique to the experiences of fragmented care, unfortunately. So as a family, we've had to do a lot of thinking on the spot or utilizing local providers. And so I really encourage, although the importance of subspecialty multidisciplinary care teams that we've talked at length about today is crucial, I think, to the care and outcomes in intestinal failure. I think it's also very important to have a local team that is flexible to you as a patient and family and understands you as a patient and family know you best, so you have the flexibility of having some autonomy. So we've been in situations where we've asked providers, can you order this x-ray, versus provider saying we'll order the x-ray, or provider dictating versus patient and provider shared decision making and then dictating. And that's
Absolutely
get this far. And without vascular access, I mean, there's a lot of things that have no more options, where we have to be very creative in the system that we have. Otherwise, I would be stuck in a hospital bed.
I think that another opportunity, since these therapies, the home, enteral, and parenteral nutrition, are really, for the most part, coordinated and monitored and managed by home infusion providers, that could be a valuable opportunity for them to advocate to the prescribing physician on your behalf. So I think that you have a tendency to find more expertise and knowledge among the pharmacist or the dietitian or the nurse in the company, who could make the connection directly with the physician to help bridge that conversation and topic. The other thing, and Dr. Iyer certainly dropped a little point about advocating to your clinician or your physician to ask the question and present your case at an ECHO meeting. And I think that is the best way. I think Swapna said it, and I sort of hinted at it too. But I think that, we want to try to reach out, because we think this is a valuable education opportunity. And the people who tend to come are people who have knowledge and experience and are interested in intestinal failure. So how do we get at that, physician prescriber who only has 1 or 2 patients with intestinal failure? And I think the patient could say, oh, I learned about this Learn Intestinal Failure telementoring program. There's an opportunity to present case. Would you be willing to present this case and ask on my behalf? I've heard many presenters, so other clinicians presenting a case, say that they told the family or the patient that they would be presenting their case anonymously. We've told our patients we've presented and asked those questions, and then we come back with them to the answer. So I think that is the best way to really start bridging this. How do patients get involved in Lift Echo?
It's funny you say that, because I literally made myself a little sticky note over here and put it on the side during his talk that says, talk to Dr. So-and-so, my doctor, about Lift Echo. So clearly I even need that. My son's the only one she manages here. It literally. So, and the last conversation we had with her was not about quality of life, though I had that in my head. So I was asking her some of those questions or sharing some of those things with her without the the QL data in front of me.
Yeah, everything, the case presentations go from, diet to transplant and everything in between, management, vascular access, for other medications, research study. I mean, it's the whole continuum of management of intestinal failure. Not every case discusses every single element of that. So
No, the
Right.
dynamics are
Absolutely.
they're very powerful. And that is something as a team that we're considering and hoping to do more of, is grassroots campaigning to bring more awareness of Lift Echo to the patient, to then educate their clinicians, because that side of it, this is just one presentation, and hopefully we can continue to do posts and other things to bring
it reminds me, I had a graduate student a couple of years, it's probably 10 years ago now, who did a qualitative interviews among home parenteral nutrition and home enteral nutrition consumers that she recruited through Oley. And it was designed, the study was really to try to get an understanding of the value of Oley. And her findings, there were many, but one that really jumps out is the consumer as the educator of the clinicians. And I'm sure many of you have had that experience in terms of sometimes nursing and home care management and how the line is handled and various other things. But you as the consumer are often educating the clinician because you're learning in this environment.
Absolutely. Well, and I know this is a little bit out of order here, but yesterday and then again today, there's a couple questions about, what is intestinal failure? And I can tell you, even at Aspen, I had several conversations with several different doctors, and they all have different definitions of it. So what is intestinal failure?
So, I don't have the actual published definition right here in front of me to read, and there are those things, but basically it's not having enough functioning or length of intestine to adequately support nutrition and hydration needs. So that's where this dependency on home PN kind of gets stuck with that definition. Now, pediatrics has a very specific definition, and if Savan is here, maybe she can pipe on and give that, but that one actually has time frame embedded in the definition in terms of the length of time dependent on PN. But basically, intestinal failure is when you can't support yourself by food and fluid alone.
And then one question on here is, what's the beginning symptoms of intestinal failure?
Well, there are many etiologies or reasons that people end up with intestinal failure. So surgery that leaves somebody with not enough intestinal surface area. So that could be acute. There could be a problem with blood supply to the intestine, and there's severe abdominal pain. Somebody ends up in the emergency room and gets emergently taken to surgery and wakes up and learns that they have short bowel syndrome or intestinal failure. There are inflammatory bowel disease related etiologies, so that if somebody has longstanding Crohn's disease or other inflammatory bowel that's required surgery over time, multiple surgeries could get you to that point. There could be malabsorptive symptoms, and then there are a lot of the childhood disorders, necrotizing enterocolitis, gastroschisis, Hirschsprung's, and some of those things that lead to it. But I think in general, most people have diarrhea, weight loss, dehydration, malabsorption, maybe some unusual vitamin and mineral deficiencies or very specific electrolyte deficiencies, and everything in between.
Thank you. So as we wrap up a little bit here, I'd love to, I'm going to give Swapna and Marion a chance to say any last things that you want to say here. So Swapna, you first. If there's any comments, questions, whatever you want to share, here's your chance.
Well, no, thank you for having us. And this is just the beginning of sharing more about Lift Echo and how the Oley community can get involved. And again, I really want to harp on how you really can advocate at any point in your journey, and advocacy can evolve throughout your journey. As I shared, like I started in one segment, just trying to connect with different organizations, and then now I'm more into the research side. But it can work for any place you are in your disease state, as well as for your passion. So please don't have any fear in speaking up. It's very, I think, an innate part of us, and you're very validated to do it and to share your voice.
Thank you for sharing your voice, Swapna. You're always such an inspiration. Thank you so much. And then Dr. Winkler, a last thought from you.
Well, I'll say something that I'm sure Dr. Iyer would have said, and that is watch this space.
Oh yeah.
There's so much research over the last couple of days. I've got a piece of paper over here that's a mile long of thoughts of that have been coming to my head, maybe next year's conference, things in between here and next year. And one of the themes that comes through is we need a lot of more research in this space. We need a lot more advocacy in this space, and we need everybody's all hands on deck. So thank you so much for joining us today, Dr. Winkler and Swapna. Thank you so much. I'm going to kick it over to Joan Bishop now for a few words, and then I'll wrap up a little bit for the end of the day.
I'm just going to say, Marion, I have never heard Kishore Iyer be so brief. Are you sure that's all you think he would say?
Well, given the fact that he had the opportunity to present twice, yes, watch this space.
I want to thank you. Thank you all. This has been a wonderful day. I think each and every day was just absolutely to the moon, fantastic. So I will start by thanking our corporate partners for supporting our important work throughout the year, to our conference sponsors and those who helped us market this meeting. We enjoyed 523 attendees this week. It's remarkable, and every day was just as inspiring as they possibly could be. I want to give a nod to the dedicated Oley staff who stepped up in a huge way to cover responsibilities for me when I fell ill about 2 weeks ago with COVID. I was not able to contribute much towards the last minute details, but I really do appreciate it all. To the speakers who volunteered their time to share expertise to further everyone's understanding of the therapies that sustain Oley members, gratitude beyond measure. A special nod to the wonderful audiences we enjoyed this week. Your questions and interactions via the chat contribute greatly towards everyone's conference experience. Thank you. The conference recordings will be posted soon on oley.org. We've heard a lot about advocacy and the importance of using your voice right up to the last minute with Swapna's remarks. I'm appealing to you now for everyone to use their voice and help raise awareness of Oley2022 in your circle of friends. Let's use our voice to share how the experience is enlightening, and you always walk away with a nugget of information that you can put to use. Perhaps one person will choose to tune in and learn more about Oley and these meetings. And let's all begin to share enthusiasm for Oley 2023, planned as an in-person meeting with a virtual arm. Imagine having the conversations you had via the chat this week, being with people who stand in front of you or sit next to you. And one more thing before Oley 2022 comes to a close. You will receive conference evaluations along with a brief survey via a Zoom link. please take the time to share your opinions and suggestions with us to help us shape programs that better serve you. Oley is your organization. And with that, I'd like to propose that we close the meeting. And thank you, thank you, thank you.
Before we run, we've got one more thing, Joan. We got some
Oh, the
exciting
marketplace.
winners to announce.
Yes, we do. And
So I can do that real quick. Thanks, Joan, for your words. Thank you for your words. I just want to announce really quickly. Thank you for everyone who took the Marketplace Challenge. We've got winners from the drawings. I'm sorry if I botched your names. I'll try my best. Congratulations to Mallory Moharo and Ted Zloff, Carrie Sheehan, Amber Cox, and Paula Reese. We will be reaching out to them to make arrangements to have the prizes shipped to you. So congratulations for taking the challenge and for winning. And then, as Joan said, please complete the conference evaluation. Your feedback is so important. You'll be getting we'll be receiving this feedback because we want to know where we go from here, not just for the conference, but all the next year. And again, thank you to all of our presenters and participants for joining us for 2022. That's a wrap.